Hi friends, I'm Dr. Kunal Pai and today we're going to be launching a new series of lectures for doctors. It's going to be helpful for MBBS students, postgraduates and even super specialists. So do let me know how you find this series, and if you have any suggestions or you want me to cover any topics, do let me know in the comment section. So hi friends. So today we are going to be talking about the approach to antenatal hydronephrosis. And it's a very important topic in two aspects. One is, as a general pediatrician, you are going to encounter this scenario a lot of times. This is going to be the most common congenital anomaly which parents are going to come to you with. So you have to know as to how to approach, whom to refer, and when to refer. And as far as from the exam point of view, yeah, you can get a 10-mark question. So it's important in both ways. So what exactly is hydronephrosis or hydroureteronephrosis? So the dilatation of the renal pelvis is known as hydronephrosis, and the dilatation of the ureter and the pelvis is known as hydroureteronephrosis. So just to understand, this is the kidney, this is the pelvis, this is the ureter and the bladder. So if the pelvis is only dilated, it is known as hydronephrosis. And if the pelvis and the ureter is dilated, it's known as hydroureteronephrosis. So why is antenatal hydronephrosis so important? Number one, we can detect these urological issues as early as the second trimester. And remember, if we miss them, it can lead to renal and bladder dysfunction. And if we have detected them early in pregnancy, then we can counsel the parents and offer early postnatal interventions, and they have really good outcomes. And remember, we are in the age where fetal interventions are possible, although in a very few centers. But since they are available, if required, we can refer these patients to the following centers. So, how common is antenatal hydronephrosis? So, of all the anomaly scans done, 1 to 5% of the scans will show a hydronephrosis, either unilateral or bilateral. Of these, 41 to 88% of the scans do not require any intervention after birth, and the hydronephrosis self-resolves. And even if it doesn't resolve, it won't be harming the kidneys, although it persists. The remaining lot is the one which does require intervention. And if intervention is not provided at the right time, it can lead to renal dysfunction. So before we proceed ahead, we should know certain important terminologies. Number one is isolated hydronephrosis. So basically, it means hydronephrosis without any ureteric or bladder anomalies. Number two is bilateral hydronephrosis. That means hydronephrosis involving both the kidneys. Or if the patient has one kidney, then hydronephrosis in that kidney is also considered as bilateral hydronephrosis. And lastly, APD, that is the antero-posterior diameter of the fetal or the neonatal kidney. So what exactly is this AP diameter? So if you look at this kidney on the left side, if you look at the kidney from the front, this is the kidney and this is the pelvis and this is the ureter. So this horizontal line, this is not the AP diameter. So to understand the AP diameter, just slice the kidney along this violet line, okay, and then you're looking at the kidney from above, from like if you're looking from the head on view, okay. So this green line, which is the anterior posterior part of the pelvis, this is the AP diameter. So what are the causes of antenatal hydronephrosis? Number one, the most common one is a PUJ or a pelvic-ureteric junction obstruction. Number two is a VUJ or a vesico-ureteric junction obstruction. Number three is a VUR or a vesico-ureteric reflux. Number four is PUV or posterior urethral valve. Number five is an extrarenal pelvis, which I'll explain in the diagram. Number six is a megaureter. And number seven is a ureterocele. So now we'll understand all those causes in diagram form. So this is the kidney, this is the pelvis, this is the ureter. So any obstruction at this level is known as a PUJ obstruction. This is the kidney, this is the pelvis, this is the ureter, and this is the bladder. So any obstruction at the level of the vesico-ureteric junction is known as a VUJ obstruction. So now this is the bladder and this is the ureter. So when urine refluxes from the bladder to the ureter, we call it a VUR. And this is the bladder and this is the posterior urethra. So due to a valve here, there is obstruction to the flow of urine from the bladder to the urethra, which leads to back pressure changes in the bladder, and further that leads to reflux of urine in either one or both the kidneys. Now coming to extrarenal pelvis and megaureter. So in extrarenal pelvis, basically the pelvis is intrarenal. So what happens is, if the same pelvis is outside the kidney, it looks like a hydronephrosis, but it's not actually a hydronephrosis. So basically it's a benign condition which mimics a hydronephrosis, but there are no clinical implications. And as far as megaureter is concerned, basically the ureters are congenitally dilated. So that means that it's not because of any back pressure changes or any obstruction. Okay, so there's no reflux or VUJ obstruction or PUJ obstruction. The ureters are congenitally dilated. It's not a high pressure system. So it doesn't lead to any back pressure changes on the kidney. So both these conditions are benign. So now coming to ureterocele. The ureter has two ends, a proximal end connected to the kidney and the distal end connected to the bladder. So now in ureterocele, what happens is basically the distal end gets dilated, okay, giving the appearance of a ureterocele. At this point, there might be also an ectopic ureter, and that can lead to reflux causing hydroureteronephrosis. So now that we have understood all the causes of antenatal hydronephrosis, let's begin the approach. So when do we diagnose it? So antenatal hydronephrosis is picked up in the second trimester anomaly scan. And once it is picked up, it is classified into different grades. So there are three types of grading systems. The first one is based on the pelvic AP diameter. So here the absolute diameter decides which category it falls into. The second one is this SFU classification, which stands for the Society of Fetal Urology. So it's based on number one, the pelvic dilatation, and the second one is the parenchymal status of the kidney. Here there is no absolute AP diameter measurement. And the third one, which is the UTD classification, UTD stands for urinary tract dilatation. So here it detects whether there is presence or absence of dilatation. So just to understand what we just discussed, so based on AP diameter, the hydronephrosis is categorized into mild, moderate, and severe. Okay, and in the second trimester, if the AP diameter is between 4 to 6 millimeter, it is considered mild. 7 to 10 millimeter, it's considered moderate, and more than 15 millimeters is considered severe. And in the third trimester, if the AP diameter is between 7 to 9 millimeters, it's considered mild. 10 to 15 millimeters, it's considered moderate, and more than 15 millimeters, it's considered severe. So basically, if it's more than 15 millimeters in any trimester, it is severe hydronephrosis. So now the same hydronephrosis, if you want to grade as per the SFU classification, then you have four grades, SFU1 to SFU4. In SFU1, the pelvis is barely split, and in SFU4, it becomes as bad as the parenchymal shows thinning. And if you want to classify it according to the UTD classification, then we have UTD A1, where there is central or no calyceal dilatation. And in the UTD A2 to 3, we have any of the following features like peripheral calyceal dilatation, abnormal parenchymal thickness, appearance of ureters, which is abnormal, abnormal bladder appearance, or unexplained hydramnios. So when it comes to clinical practice, nobody usually uses the SFU or the UTD classification. Everybody uses the AP diameter classification. So remember, when the pelvic AP diameter is more than 4 millimeter in the second trimester or more than 7 millimeter in the third trimester, we call it antenatal hydronephrosis. How do you remember this? 4 and 7, it's very confusing at times. Simple. Just remember the mnemonic 24/7. So what it stands for? 2 meaning second trimester, 4 meaning 4 millimeters. So 4 millimeters in the second trimester, and 7, it's the third number. So that means 7 in the third trimester. So now you've detected hydronephrosis, but then how do you proceed ahead? Because that's very important. Just detecting hydronephrosis is not the only thing. So how do you proceed? Simple. Just look around the hydronephrosis. What else do you see? So number one, we see the kidney, whether it's enlarged or whether it's cystic. If it's showing that it's enlarged or cystic, that means that it's a high pressure system, maybe a PUJ or a PV. We don't know, but at least it shows that it's a high pressure system. Then look at the urinary tract, whether that's also dilated, because if that's dilated, then maybe it could be because of a VUR or a PUV. Then look at malformations in other systems. So basically, it could be some genetic disease which is also having hydronephrosis. And lastly, look for soft signs. So your next question will be, what are these soft signs? So soft signs are basically subtle abnormalities in the fetus which may give us a clue as to whether the fetus is having a renal or a urological abnormality. So the ones which we are looking for are oligohydramnios or a thick walled or a dilated bladder. So basically the significance of oligohydramnios is simple. The fetal urine basically is the amniotic fluid. If the amniotic fluid is less, that means that either the kidneys are not producing enough urine or there's obstruction to the urinary flow. So this gives us a clue as to whether there is any renal or a urological abnormality. And as far as a thick walled or a dilated bladder, so basically that happens when there is a PUV because of the high pressure changes in the bladder. So if there is isolated antenatal hydronephrosis, you don't need to do any karyotyping, as parents are very worried as to whether these soft signs require any genetic testing. But if there is an antenatal hydronephrosis with an extrarenal anomaly, you can do a karyotyping. So the ones we talked about of oligohydramnios and bladder wall thickness were related to the kidney. The other soft signs for other systems are increased nuchal translucency, echogenic focus in the heart, absent nasal bone, shortened long bones such as the humerus or the femur, an echogenic bowel, a choroid plexus cyst, or ventriculomegaly. So how do we monitor the hydronephrosis during pregnancy? So basically we come with three scenarios. The first one is that you have unilateral hydronephrosis. So that's the most easiest scenario. That's why the green color. So if you have unilateral hydronephrosis in the mild to moderate range, then you can repeat the scan only in the third trimester. You don't need much follow up with it. But if you have bilateral hydronephrosis, then you have to repeat a scan 4 to 6 weekly. Also remember, this is a very subjective thing. If you have severe hydronephrosis or you have features of lower urinary tract obstruction like bladder wall thickening, then you might have to repeat scans much more frequently. Even if you have oligohydramnios, you have to repeat it much more frequently. And lastly, if you have extrarenal anomalies along with the hydronephrosis, then you have to refer the patient to a higher center. So now you have your patient with bilateral hydronephrosis and you're monitoring with USG scans every 4 to 6 weeks. But how long do we do this? Is there any end? Or do we have any fetal interventions to be done? Yes. If we suspect a lower urinary tract obstruction and there is oligohydramnios, then only at specialized centers do we do these interventions. Remember, termination of pregnancy is not recommended unless there is presence of any extrarenal life-threatening abnormality, and fetal vesicocentesis is preferred in lower urinary tract obstruction. And also remember that these fetal interventions don't always have a good outcome. There can be fetal wastage. So this should also be told to the parents before we go ahead with any intervention. So coming to the next step. So you've been monitoring your patient throughout pregnancy. Everything's fine. You do not need any fetal interventions. And now your patient is born. Now what do you do next? So remember, the first scan should be done between 3 to 7 days. So keep it a protocol that before discharge, a USG should be done. But if you suspect a PUV, or the patient has oligohydramnios, or there is severe bilateral hydronephrosis, then you get the scan done within 24 hours. So now your child is born and you've done the first scan, and let's say the child had an AP diameter on one side of 9 millimeters. So when do you do the next scan? So the next scan is done at 4 to 6 weeks. And if both these scans are normal, then there is no significant urological issue. You should remember that you should continuously monitor this patient every 3 to 6 months till the age of 5 years, till there is complete resolution of the hydronephrosis. So then you're doing your scans and your child is fine. But then you always hear that in hydronephrosis, you need to do an MCU or a DTPA. So when do we exactly do these tests? So MCU should be done only in specific cases, not all. So if there is unilateral or bilateral hydronephrosis with a pelvic AP diameter of more than 10 mm, or an SFU grade of 3 to 4, or there is ureteric dilatation, then you need to do an MCU. Or if the child has a UTI, then also an MCU is warranted. So remember, timing of MCU is very important. If you're suspecting a PUV, then you have to do it within 24 hours. But if you're not suspecting a PUV, then you can do it at 4 weeks. So then when do you do a DTPA? Basically, remember, MCU is for identifying picking up a reflux or PUV, and DTPA is done to pick up a PUJ obstruction. So when infants with moderate to severe unilateral or bilateral hydronephrosis do not show a VUR, that's when you do a DTPA, and it's done at 6 weeks. The other options we have are a MAC3 or an EC scan apart from a DTPA. Remember, patients with VUR and worsening hydronephrosis also require evaluation for pelvic-ureteric junction obstruction, since the two may coexist in 7 to 18% patients. So you've done your scans, you've done an MCU, or you've done a DTPA, and you get your results. So when do we exactly operate? So it depends on the pathology, based on if it's a PUJ, yeah, a VUR, or a PUV. We'll discuss each one of them. So, in PUJ obstruction, there are definite indications of surgery. If you do a DTPA and the differential function of one kidney is less than 35%, or the pelvis diameter is more than 30 millimeters, or the creatinine is rising, or in between two DTPAs, there is a decrease in function of one kidney by 5 to 10%, or you have a single kidney, you have to operate. Remember, the surgery of choice is a pyeloplasty. When we talk about VUR, the indications for surgery are recurrent UTIs, high grade reflux, breakthrough UTIs on uroprophylaxis, if the child has a single kidney or the child's creatinine is rising. The choice of surgery is reimplantation of the ureter, but it can be only done when the child is at the age of 1 year. Before that, if the child is having recurrent UTIs, you can do a deflux or a ureterostomy. When we come to a PUV, then it becomes like an emergency. If the child is not passing urine, you catheterize the child immediately. Normalize the electrolytes and the acid base balance first. Then do an MCU to confirm a PUV. And once a PUV is confirmed, do a cystoscopy as early as possible and do a fulguration of the valve. And lastly, we come to the question of antibiotic prophylaxis. So, when do we give it? So, if we detect hydronephrosis, we can start prophylaxis immediately till we come to a diagnosis. If we diagnose a PUJO, we can stop prophylaxis as there's no reflux of urine till the kidney. But if we diagnose a VUR, then if it's grade 1 or 2, then we continue prophylaxis till the age of 1 year. If the child again has a UTI, then we restart it. If it's grade 3 to 5, then we continued the prophylaxis till the age of 5 years. So let's summarize what we all discussed. When to pick up antenatal hydronephrosis in the second trimester. How to proceed during pregnancy. So once you've picked up the hydronephrosis, look at the kidney, look at the lower urinary tract and the extrarenal organ systems. How to evaluate in the immediate postnatal period. If it's a mild grade, then you can just do a scan in the third trimester. If it's bilateral hydronephrosis or you're suspecting lower urinary tract obstruction, repeat scans 4 to 6 weekly. How to follow it up? After the child is born, get the first scan done within 7 days and then repeat it at 4 to 6 weeks. When do you do an MCU? If you're suspecting a VUR or a PUV. If it's a PUV, then within 24 hours. If it's just a VUR, at 4 weeks. As far as DTP is concerned, if you rule out a VUR, then you do a DTP at 6 weeks. When to give antibiotic prophylaxis? As soon as you diagnose an antenatal hydronephrosis. You can stop it once you rule out a VUR. And when to operate? Well, we have discussed the absolute indications for all three conditions. These are our references, and we have referred to the ISPN guidelines on antenatal hydronephrosis. If you found this video useful, please like, share, and subscribe to our channel. You can follow us on Instagram, Twitter, and Facebook. Hope you like the video, and see you soon in our next video.